Okay, so this is an 86-year-old woman who came to the ER with tachypnea, confusion, and ataxia. And there was some CKD, history of a peptic ulcer, intestinal obstruction. She had a gastrojejunostomy, and she was given supplements that contained Lactobacillus acidophilus. She was also being given mulberry juice and sugar. And on exam, she was afebrile. She was breathing pretty quickly. Blood pressure was a little bit elevated. And on abdominal X-ray, she had some distended intestinal loops. And you see her numbers here. So does anyone want to unmute and go through what they think? First, focus on the electrolytes. And again, you know, when you learn something, it's best that you make mistakes and just make your mind commit to something. Don't worry about being totally wrong. There's no embarrassment here. The idea is to fine-tune your thinking so that you'll be able to make these diagnoses better than your attendings. Anyone? Sure.
I'll try. So you said always look at the bicarb first. So which one is the bicarb? Well, I can see it on the
that's a good point. So the 5 is the total CO2 from the panel. The bicarb is calculated from the blood gas 3.9. It came back at.
Okay, so the bicarb is low.
Very good. The bicarbonate's low.
It looks like if we're looking at the rest of the electrolytes, the sodium is within normal limits, potassium is within normal limits.
So when you say the bicarbonate's low, immediately state the 3 acid-base disorders that will lower it.
Okay, so it is either a metabolic acidosis, an acute respiratory alkalosis, or a chronic respiratory alkalosis.
Excellent, excellent. Okay, so before going to the rest of the electrolytes, since you started the bicarbonate, which is fine, we could have started looking at the non-acid base issues. Obviously, the BUN and creatinine are elevated, and a bit of dysnatremia. But since you started with that, and you are right, it's one of those 3. It's either metabolic acidosis or acute or chronic respiratory alkalosis. Now the question is, which of the 3 is it? Or is it none of the 3? Is it a mixed disorder? So what do you do next? First, start with metabolic acidosis.
So for the metabolic acidosis, you would look at the ratios, like the change in the bicarb from normal and the change in the PCO2 from normal.
Okay, so what is the change? It's a woman, so we always have to be cognizant of the fact that women don't have a PCO2 of 40 if you look at population on average, and don't have a bicarbonate of 25. It's usually 38 as a mean and 23. I mean, you never know in a given individual, and no one has studied women in their 80s to see whether they have the same acid-base rule, or men for that matter. No one's really looked at age dependency of these rules. So we simplistically just assume population mean. So let's assume that her normal PCO2 is 38, which we don't know. And let's assume bicarbonate's normally 23. So what are the delta for each here?
So the delta for the PCO2 would be around 28, or it would be 28.4.
You don't have to go to the decimal place since it's so inaccurate anyway, but you're right. Yeah. And the bicarbonate?
And for the bicarbonate, it would be 19.
Okay, so that means that we have a fallen bicarbonate of 19, and if it's a metabolic acidosis compensated, the PCO2 should fall by around 19. Roughly. Right. So if you're right, so it can't be just a compensated metabolic acidosis is what you would conclude from that.
Right, yeah.
Okay, so now go to acute respiratory alkalosis. Could it be that?
So for an acute respiratory alkalosis, you would expect the for every 2 drop in the bicarb, you would see a 10 change in the PCO2. And so 28 to 19, I think is still, it doesn't match that either for the pure acute respiratory alkalosis.
Right. There's no way that bicarbonate would be falling that much. It would fall much smaller amount. Correct. So it cannot be acute hyperventilation. Could it be someone who's been chronically hyperventilating?
So for that, you would expect for every 5 drop in the bicarbonate, you would see a 10 drop in the PCO2. And so that would be, I think that still doesn't fit the picture completely.
Correct. So we have here a drop in bicarbonate. It must be one of the 3. There's nothing else that does it, but it doesn't fit any of the acid-base rules. So we know by definition, we have a process that's dropping it. So it's got to be one of the 3. We still don't know which one, but there must be something else. So we know we have a mixed disorder, but at a minimum, it's one of those 3. Could be any other acid-base disorder on top of those, one of those 3 or 2 of those 3, but there's nothing else that'll drop it, and there's a net drop. So that's sort of how you think about it. You look at whether it's one of the 3, it's not. So it's a mixed disorder, but it has to be at least one of those 3 because it can't be any of the other 3. They all raise the bicarbonate. So that's very good. Okay, is there any other clue as to which of the 3 it might be as a start?
Well, we also see the positive ketones and the positive lactate.
Oh, those are negative.
Oh, negative. Oh, sorry. Oh, I see now. Okay.
Yeah, that would be nice if they were positive, but they're not. That's why this case is more complicated. But going along with that, what else do you see in the electrolytes?
Well, the osmolar gap is normal. And then, we don't have, we can calculate an anion gap.
Very good. So what's the anion gap?
It is 147 minus 123, so 24.
143.
Oh, for the anion gap?
No, for the sodium. I think you said 147.
Oh, I was adding the sodium and the potassium.
Oh, I see. Okay, I'm sorry. Yeah, you don't typically do that.
Right, only for the urine.
If you do that, then your normal anion gaps are not going to be 11 or 12. So typically we don't include the potassium. Of course, logically we should, but logically we should be adding up all the cations and anions.
Right.
We don't do that. So yeah, you just use the sodium and the chloride and the total CO2.
Okay, so 143 minus 123 would be 20.
Yes, very good. So again, we don't know what the anion gap in this person was. We have to assume population means. We do want to rule out patient-specific issues where the anion gap may not be what we would expect for the population, that being 11 or so, 11, 12. And that has to do with whether the albumin's low, because the albumin contributes to the anion gap. Albumin has a net negative charge, and it's protonated. It's a buffer. It has a lot of amino acids that are charged, but the net is negative. So people who are hypoalbuminemic lose part of their anion gap, lose unmeasured anions that would normally be there, and their anion gap is not going to be 11 or 12. It'll be decreased based on how much albuminemia they have. So you would like to know that the albumin was normal so that you can assume at least what the population would have for an anion gap. We don't know that. Let's just assume the albumin was normal. And as I mentioned before, there are some hospitals where the anion gap is actually less than 11 or 12 because the machine measures chloride high, gives you a normal chloride higher than other hospitals. So let's say if in our hospital we did 1,000 patients and their chlorides were 100, this other machine would give you, let's say, 104, 105. And so the anion gap that you calculate is going to be less. It's an artifact of what the true chloride is. That's a separate issue. So you really need to know what the average is, not just for the population in a general sense, but you really want to know when you go to a hospital, what is the anion gap normally in this hospital? And unfortunately, few people can tell you that. So you just have to get a feeling from nephrologists or other people. You can ask the clinical lab if they know. Most of the time they don't know. But it can be hospital centered because it's machine centered. So what hospital are you in? What's your patient albumin before you assume what the normal is? And again, in this case, we don't know the albumin, and most of the time you don't know what it is for your hospital. But at UCLA, it's usually 11 or 12 if you don't know. The best thing is true for all of nephrology is you should try to see what this patient had in their previous admissions or medical records to get what the anion gap was when they didn't have these electrolyte abnormalities. That's the best thing to do. So you do a paired comparison within the same patient. Okay, so the anion gap's 20. With all these provisos, we'll assume it's, 10, 11, 12. We don't really know. So it's up by about 10. So the anion gap has increased by 10. The ketones are negative. The lactate's negative. So we know if it's endogenous that there must have been a proton coming in with the anion, because we don't have sodium or potassium or ammonium or other cations coming in, or calcium or magnesium. We don't have these other monovalent or divalent cations coming into the blood when we have organic anions infused into the blood. They come in with a proton all the time. So it's always coincident with a metabolic acidosis. Remember, the organic anion that's raising the anion gap is not causing the metabolic acidosis. It's not a bystander, but you have a complex compound coming into the blood. You have this organic anion coming in, which normally isn't there, and we have a clue that it's there. Not that we measured it initially here, but we have a clue that the anion gap's elevated. But we have to immediately think that organic anion came into the bloodstream with a proton. I mean, they're made in the cells, so they're, it first acidifies cells, as we showed last week, and then it gets into the interstitial fluid, then it gets into the blood. So it's in the ICF and ECF compartments, those protons. They have a volume of distribution, which we won't get into today, but it's not just extracellular protonation of bicarbonate. It occurs in the cells too, where they're made initially. But the bottom line is that's the cause of the metabolic acidosis. So the thinking is, if you know there's an organic anion elevation and you have a low bicarbonate, the logical thinking is a proton came in with the organic anion and protonated the bicarbonate to lower it. So at a minimum, we know we have an anion gap type metabolic acidosis. We don't know what the organic anion is yet. But then we go back to what you said initially. Well, if that's the case, and the bicarbonate fell, let's say from, we don't know exactly, 23 to 4, it fell by about 19, we would expect the PCO2 to be down by the same amount, and the PCO2 fell more than that. So the thinking is then, if we're right, and we have no reason to think otherwise, since the anion gap's elevated, that there's an anion gap type metabolic acidosis, then what must the patient also have?
They must also have an acute or chronic respiratory acidosis.
Acidosis or alkalosis?
Oh, no, alkalosis.
Right. So they must also have some type of respiratory alkalosis for some period of time. We don't really know. So yes, that's correct. So if the PCO2 is below what you'd expect, and we'd expect it would only be down 19, assuming it started at 38, you can do the math and see what it should be, but it shouldn't be 9.6. So there's the ventilation here exceeds what we would predict for compensated metabolic acidosis. That's fine to say that, but you're not really saying what the additional acid-base disorder is when you say that. So it's fine to say the patient didn't compensate properly, but then you also have to commit yourself to what the additional acid-base disorder is to account for all these numbers. We have to account somehow for why the PCO2 is 9.6 and the bicarb's 3.9. And unless you say, in addition to the metabolic acidosis, there's also a respiratory alkalosis, you're not accounting for all the numbers. Now, again, we didn't look at the pH, as you notice, and we don't need to. The pH can be nothing but 7.22 with a PCO2 of 9.6 and 3.9, because once you define what the PCO2 and bicarbonate are, according to the Henderson-Hasselbalch equation, or any acid-base equation you want to use, the pH must be 7.22 because all these numbers are interrelated. It can't be anything but that. If it's not that, there's an error in the pH electrode from the lab or something. So again, not only do we not need to know it to come up with a diagnosis, but it must, but if I blocked out the pH of 7.22 and asked you, what is it? You should be able to calculate from the PCO2 and bicarbonate that the pH must be 7.22. You remember that initial formula that we showed a number of weeks in a row where the proton concentration equals 24 times the PCO2 over bicarbonate. So you calculate, you take 9.6, multiply it by 24. Some people use 25, divide by 3.9. That'll give you a hydrogen ion concentration. And it'll come out to about 64, 63, 64. And you take the negative log of that, and you'll get 7.22. So it's a good exercise to do anyway, just to make sure that you can go through this thinking. And it's pleasing also to be able to do that. I mean, you feel very nice when you can take this and calculate what that must be. Okay, so the patient has an anion gap type metabolic acidosis of some sort, we don't know yet, and a respiratory alkalosis. That's why the PCO2 is lower than we would predict. There also looks like there's some either AKI or CKD, we don't know. The BUN is clearly out of keeping to what the creatinine is, so the patient likely has volume depletion as a cause of pre-renal failure. Now, throughout your fellowship, if you don't do it already, you must distinguish. There's sort of a bunch of words in English people have come up with to assess someone's volume status. And this is a bit off topic, but we might as well discuss it now briefly. When someone has significantly less blood volumes, to the extent that their blood pressure's down, their JBP's down, they have a sinus tachycardia, they have postural hypotension, whatever. There's many terms that people use, and you really should only use one. Some people say they're dry, some people say dehydrated, less people say volume depleted. Unfortunately, the correct term is volume depletion. You should not call this dehydration, and you should never use the word dry. So what's the difference? When someone's volume depleted, it means they have the clinical sequelae of having lost a certain amount of volume from their blood vessels, usually about 500 milliliters, half a liter or more, you get these findings. Dehydration only means that you've lost pure water from the system. And it is a distinction, because if you lose a liter of saline versus a liter of, deionized water, in one case, you could get hypotension, tachycardia, et cetera, et cetera. You lose a liter of distilled water, you're not going to have any symptoms at all. Both people lost a kilo. One of them you call dehydrated, the other you call volume depleted. And that has to do with the fact of this simple question. If you lose a liter of distilled water versus a liter of saline, how much of that fluid came out of your blood vessels? I'm going to leave that as a question for you, and perhaps I'll let some of you, well, why don't you all calculate it and email me the answer? So here's your question. You lose a liter, for every liter of pure water loss, how much water came out of your blood vessels versus, and that would be someone with central or nephrogenic DI, versus someone who's vomiting or has diarrhea and let's say loses a liter of saline. Both lost a kilo, so that doesn't help you. So with the saline loss, how much of that liter came out of the blood vessels is the second number you should send me. Okay, so try to calculate that. But the bottom line is that for the second case of the saline loss, never use the word dehydrated. That's called volume depleted, and do that for the rest of your fellowship and your career. And you'll hear attendings use all sorts of different words, but just, block your ears. Whereas the water loss, pure water loss in central and nephrogenic DI, that's what you say. That's when they use the term dehydrated, and don't use the word dry. That's a term medical students and residents use, but stop saying that, because you're not, what you want to do when you're using these English words is convey what medically and physiologically is going on with your patient. Now, obviously, the thought is that the other person understands what you're saying. Okay, so getting back to this case, we have some organic anion floating around, and we have a respiratory alkalosis. Now, given this clinical history, does anyone want to unmute and tell me what they think the organic anion might be? There's a clue here. The clue is that the patient's biofilm supplements were containing this organism, Lactobacillus acidophilus. And that there was carbohydrate.
Could it be a D-lactic acidosis?
Excellent,
For the
excellent.
gastroduodenal?
Yes, excellent, excellent. So when you see this organism, bang, you have to have the next neuron in your brain has to, and especially in this clinical scenario, immediately delactate. Immediately, don't hesitate. It should be, that's very good. Okay, so the acid base diagnosis. Oh yes, there's another issue here I forgot to talk about, and that's the non-anion gap pattern. So let's go back just for a second. Why is that the case here? Why is there we said that the anion gap went up by about 10, but why is there also a non-anion gap pattern here? In other words, the fall in the bicarbonate cannot be attributed only to the protons that came in with it looks that way, because remember what we did last week, you have to take the change in the anion gap from normal and add it to the bicarbonate to calculate what the bicarbonate would have been. So when we take that 10 or 11 from normal and add that to 3.9, we don't get 24, 25, we get, 14, 15. So it looks like there's another cause of the metabolic acidosis here or something else going on, because when we look at the change in the anion gap and add it to here, we should get 24, right? But that assumes, so the question is there RTA causing this? Is there diarrhea? What else lowered the bicarbonate? We can only account for getting it back up to 14 or 15. Does everybody understand that thinking? Okay, so whenever you have an anion gap change, you immediately add it to the bicarbonate that you have now to see what it would have been had you not had that influx of a proton organic anions. It makes sense. There's a lot of subtleties associated with that. It assumes the volume of distribution of the proton and the organic anion are the same. It assumes that the organic anions are not lost in the urine. And that's actually what's going on here. So the anion gap went up by 10. And if you assume that none of them were excreted, then you would have to invoke some other cause for the drop in bicarbonate. And that, there was no change in the renal excretion of bicarbonate or protons. If there was, let's say you had ESRD and you had the anion gap go up by 10, you would only get to 14 when you add the change. You'd have to come up with some other, assuming again the volume of distribution both is the same, which is in reality not the case. But assuming it was, you have to come up with another cause for the drop in bicarbonate. So what happens in this, does anyone want to explain why we're seeing this, that the anion gap changed by only went up by 10, but the bicarbonate looks like it fell by, I don't know, 20 or so? Why are we seeing that here and the key question is without having to invoke another cause for the drop in bicarbonate? That's the second part of the question. With just having a D-lactic acidosis, why does the bicarbonate look like it, when we add this delta gap to here, we don't get back to 24? What else could be going on? I mentioned it a number of weeks ago in the context of ketoacidosis, where you can have a hyperchloremic pattern or a normal anion gap pattern. And yet the only cause of the metabolic acidosis is ketoacidosis. Same sort of phenomena that occurs there that's occurring here. Anyone want to take a stab at it? Okay, so remember that we have an input-output system unless you have total shutdown of your kidney function. So yes, we have an influx of organic anions into the blood. We also have a kidney that's filtering them. And if any of those anions are excreted in the urine, your anion gap's not going to go up by as much as it would have if you had had ESRD. So that's what's happening here. The D-lactate, yes, is going into the blood, but it's also being excreted. So the anion gap didn't go up as much as it would in a patient with the same influx as this patient, but who had ESRD. In that patient, the anion gap would have gone up by 20. And then when you added it to the bicarbonate, you'd get, 24, 25. You'd have a much higher anion gap in someone with ESRD for the same influx of protons and lactate. Does everybody understand that? Okay. If anyone doesn't, just please unmute and I'll go over that again. So remember, the anion gap that you get in lactic acidosis, ketoacidosis, D-lactate, whatever it is not solely due to the influx. Remember that for the rest of your life. It's also due to how much came out in the urine. And if this person didn't have a creatinine of 3.4 and a BUN of 103 and had an excellent GFR, this anion gap might only have gone up by 1 or 2 or 3. And you say, oh, there's not much D-lactate acidosis, but that's not true. It's just the same severity. So you should never, ever, ever use the anion gap as a surrogate for how severe the proton load is. And people do that all the time. In the ICU, they look at the anion gap and in ketoacidosis and say, if it's so-and-so, keep doing X, Y, and Z. But that's not true. You can have rip-roaring ketoacidosis with a normal anion gap. Doesn't mean a thing, because they're all being excreted. The ketone bodies are all being excreted in the urine. You see that in people who are not volume depleted, who haven't been vomiting, who haven't had an osmotic diuresis with ketoacidosis. So this person did lose D-lactate in the urine, and the anion gap basically only went up half of what it would have been in someone with ESRD. And that's why when you add the change in anion gap to the bicarbonate, you only get back to 14. It's not that there's another mechanism for the drop in bicarbonate. The proton load is the same. We're not talking about a different proton load, but the anions go up and down depending on the filtration and absorption in the nephron. And again, when you don't spark, you don't change your total anion concentration. So the chloride varies inversely. The bicarbonate fell to 5 because of the proton load, but the chloride and organic anions will vary inversely depending on how many organic anions are left in the blood. If all the organic anions stayed in the blood, this chloride would be 108, not 118. Okay. And if that doesn't make sense to all of you, either say it now if you wish, or just email me and I'll get back to you to explain that. It's an important concept to always remember for the rest of your life, that the anion gap depends on the excretion also. And most people continuously forget that. Okay, so there's an anion gap metabolic acidosis, a respiratory alkalosis that we mentioned, but there's also this non-anion gap pattern. We're saying we're not calling it a non-anion gap metabolic acidosis, because if you say a non-anion gap metabolic acidosis, you're conveying to another human brain that there's another cause for the acidosis. And that's not true here. It's the same cause, but we have a non-anion gap pattern because of the excretion of the organic anions in the urine. That's the concept here. So you should always distinguish that also. Do you have a non-anion gap pattern, or do you have a non-anion gap metabolic acidosis? And people also continuously don't make that distinction. Okay, so the patient was dialyzed because they didn't respond to bicarbonate. And again, you're right. And the D-lactate was measured. It came back around 7. And again, it would have gone up much more had it not been excreted in the urine. So if you want to look into the history of this, the first case was actually reported in 1979. I said 71 there. 71, I'm sorry, in the New England Journal. Male with short bowel syndrome. And since then, there's always some GI issue. It isn't just this organism. So people with jejunal ileal bypass or resection of their small bowel or malabsorption syndrome, they can get encephalopathy. It's felt to be due potentially to the D-lactate with some metabolic products. That's a key issue also in the elderly that people always forget about. It's a side issue, but it often comes up because we always get blamed about electrolyte abnormalities. If you have someone who's 80 or 90 and they go on an antibiotic, they can actually become cognitively impaired or act very differently, paradoxically, because you got rid of an infection. And the reason is, let's say you're treating a UTI, someone who's 80, 85, you give them an antibiotic and they start acting weird. The immediate diagnosis you should think of is that you've wiped out their bacterial flora or altered it. And the bacteria that are there now are making different metabolic products that the brain is reacting to. So you can get sort of cognitive or encephalopathic or very altered behavior in older people because of an infection per se, or because of your treatment, and the treatment because you're affecting the bowel flora. And oftentimes when you stop the antibiotic, the brain gets better, paradoxically. So don't forget that either, because we're often blamed in the elderly for, is this, the sodium of 128 that's making them act like that? In fact, it's a big misdiagnosis that the electrolytes are causing, they call it toxic metabolic syndrome. And the only electrolyte that really predictably alters the brain is hypercalcemia. Sodium is blamed far too often when it's not the cause, even if it's down to the low 120s. Okay, so getting back to this patient, this is a gram-positive anaerobe, and this patient was actually ingesting this in what they were taking, and it metabolizes carbohydrates. It can be metabolized to pyruvate, and so to the extent that it is, you're not going to have the issue. And the treatment is just to withhold the carbohydrate, because that's what's being metabolized. Give bicarbonate, give antibiotics, dialyze. And this just shows the pathway. So again, a carbohydrate load is part of the clue. If you're eating protein, you're not going to get this, only protein. You need some sort of intestinal abnormality like we talked about. And then the carbohydrate is metabolized in the colon, usually to organic acids, a proton with D-lactate. And you get this organism, predominantly the one that's doing it. Either it'll be endogenous or you ingested it. It's the major cause. If you had to guess, if you had to say, of all these organisms, which one does my patient likely have? It's lactobacillus. And as I mentioned, the lactate can be metabolized to pyruvate and either get into the, metabolized in the Krebs cycle or gluconeogenesis and make glucose. So if you don't have a huge production of D-lactate, you may never see this. Doesn't mean it's not going on. It's just you don't have any evidence for it. And the other, conversely, if all the D-lactate is excreted in the urine, you'll have a hyperchloremic metabolic acidosis only. And so you're going to measure the blood D-lactate and go, oh, it's normal. This patient doesn't have D-lactic acidosis. Again, not true. You got to measure the urine D-lactate concentrate. Just the same thing as if you have someone who's volume replete with ketoacidosis, and you measure ketone bodies in the blood and they're zero. Your brain shouldn't go, oh, this isn't ketoacidosis. No, that's not true. Their blood sugar is elevated and they have the clinical scenario for ketoacidosis. Immediately say, okay, it's not in the blood, but it must be ketoacidosis. I'm going to look in the urine and prove it. And you'll see there's 4+ ketones in the urine. Same thing here. You may not have anything in the blood, and then you've got a ton of D-lactate in the urine. Again, it depends on the GFR for most of these things. It's the extent that the GFR. So if you it's a sort of a theme. If you have an organic acidosis, the anion gap for a given production rate is going to depend on your GFR. If your GFR is great, for whatever reason, volume repletion, whatever, you didn't vomit, you didn't have diarrhea, or you gave an IV saline from the get-go and kept the patient volume replete, GFR is great. That's going to decrease your anion gap. It's going to help excrete the organic anions. To the other extreme, where this occurred in someone with ESRD, where all the organic anions are still going to be floating around in the blood. Now, remember, the kidney gets rid of them, but your body metabolizes them back to bicarbonate. So there's sort of two output pathways from the organic anion once it enters the blood. It can be excreted as the organic anion, in which case you have a hyperchloremic pattern, or metabolic acidosis in this case, if it's the only cause. Or the organic anions can be converted into bicarbonate. But if that's the case, the bicarbonate won't fall. That's the difference. If the organic anions are excreted in the urine, you still have your metabolic acidosis, but your anion gap diminishes to the extent that they're excreted. Whereas if you have lactate with a proton coming into the blood, or ketones, acetoacetate or beta hydroxybutyrate with a proton coming into the blood, or D-lactate coming into the blood with a proton, if from time zero the input wasn't that great and your body could metabolize those organic anions into bicarbonate, you're never going to get a metabolic acidosis in the first place. And you're not going to get an elevation of the anion gap because the anions are being metabolized. So the fact that you don't see either a metabolic acidosis, let's say you have someone with ischemic heart disease who's perfusing their tissues but not perfusing well, and your bicarbonate's normal and the lactate's normal, and you go, well, I think this patient should have at least a mild lactic acidosis. The answer is they could have it. The cells could be sending lactate with a proton into the blood. It's just that they're able to convert the lactate back to bicarbonate at the same rate. Or other organs are. There could be partitioning of the production and metabolism. But the bottom line is, for every lactate that's made, it's converted into bicarbonate. You're not going to see anything in the bicarbonate, and the bicarbonate won't fall, the pH won't change. So you just have to keep these flows in mind. Don't just focus on the input. There's kidney excretion and there's metabolic conversion to bicarbonate. And again, we know that these organic anions, all of them, anything with a carboxyl group, can be converted into bicarbonate. We use that clinically. We have acetate in the TPN. We have citrate when we give patients, sodium or potassium citrate who have a metabolic acidosis. Or we put lactate in the PD solutions. Look at the PD solutions. They have lactate. Why is there lactate there? Because the lactate's absorbed and converted into bicarbonate. So your patients on PD don't get a metabolic acidosis. So this theme is not just something that occurs with endogenous organic anion production. It occurs therapeutically. We use it all the time, but don't think about it. Okay, so I think I'll stop there. Does anyone have any questions about this syndrome? Okay, everyone. Thank you for joining, and have a great rest of the day. And again, if anyone has questions, please feel free to email me or text me or page me. Bye-bye, everyone. Have a great day.